this is the skin incision for marking, and this is the positioning of the, say, edge to the left, and then flexed left arm will give you access in a maximal way, and intercostal space will be a bit widened. Memory takedown, we used to go for long electrocortite tip with harmonic scalpel. This is our harmonic scalpel. We actually use separate step wound with laparoscopic trocar, and through it, then hand movement will be less. You can see the incision is just forefinger. Video will not run. In our scenario, time frame from 2020 to October 22, we did 1108 cases. This year 587. Only 190 cases were minimally invasive. Out of that, 52 were of CABG minimally invasive. Out of these, 2 cases were redo, where actually grade 7 vein was utilized earlier, so failure give us the chance to go for Limato-LAD through minimally invasive access. We did 291 EVH cases endoscopic vein harvesting because we adopted only this January. 10 months we have 291 EVH cases due to actually Ukraine war and others. Nowadays, all those disposables are not available. It is difficult to import as well. We can share our 1 or 2 cases where we got some difficulties. 47 years lady, triple vessel CABG, we did 3 grafts. But after protaminization, there was profuse bleeding when actually go for the double lung ventilation. Hypotension, we reheparinized the patient, go for CPB. Actually, bleeding was from the proximal bleeding, possibly proline wire breakdown, broken down. Resuturing done, no other bleeding points seen, and patient extubated on the following day and discharged in usual fashion. And another case for EVH, actually, we had just after harvesting endoscopic vein, PA harvesting, and informed that patient's scrotum was swollen. Immediate inspection of genital shows swelled scrotum and surrounding structures. It was actually due to carbon dioxide insufflation. And another thing we were actually aware of that, giving small incision, no CPB is real minimally invasion, but giving larger incision to the leg is actually is opposite to the minimally invasive surgery. So we should adopt also minimally invasive, that is endoscopic vein harvesting, as well as our skin incision in the chest. And this is Dr. Shoikot Dasgupta published our case, mid-cab in redo settings. So at the end, we can tell and share that teamwork is at the cutting edge, because anesthesia, perfusion, scrub nurse, surgeon, and instrument caretaker are also important. Especially anesthesiologists, those who can run the show with double lumen endotracheal tube with single lung ventilation, which is really essential. And also, those who are adopting proximal anastomosis with side bite clamp, and also for the multivessel CABG on beating heart, actually without anesthesia crucial help, we can't move forward. In conclusion, I must say the following rules have to be kept in mind to be successful in MICS program, especially your initial days. Never work under pressure or in a busy schedule. Inform the whole team about your strategy and be communicative. Never accept suboptimal surgical results. I repeat, never accept suboptimal surgical results as a cost of a limited approach, because the result, the goal is always, Professor Farooq's talked to us or advised us that 2 things is important in coronary surgery. One is good harvesting conduits, and second one is the good flow with good anastomosis. It should be pakka. In a complex case, ask for assistance early on from an experienced surgeon, and exclusive tea use is mandatory. Our team, Brigadier Mujib and Dr. Bhavesh, are instrumental for that. They are helping even for debit cases, mitral aortic repair cases. They are very much ahead of us. So they help, and I am really grateful to our total team as a whole. And learning from error is a key. Thank you for your attention. And again, thank you, National Heart Foundation organizer, to give me the platform. Thank you.
Thank you, sir, for your very informative lectures. Thank you very much. Ladies and gentlemen, we have any questions? Welcome. Any question to speaker? Yes, sir. Hey, mouthpiece, mic. Question from Dr. Shakil Puri.
What is your conversion rate in pump on sternotomy?
Question is very relevant. We are actually ready to convert it to CPB, not to sternotomy, because through the thoracotomy, if we go to conversion sternotomy and CPB, it is really difficult.
What CPB? Can femoral or
Femoral? Yes, sir. We actually prepared the femoral, and for initial few cases, we even open and going for taking first string, ready for CPB at 2 to 3 minutes, like that. But from time to time, we are not now opening our groin, but we prepare groin for CPB establishment through femoral.
Thank you, Dr. Prashanto Chanda, for your excellent question, excellent presentation. Just really a comment about the EVH. So I was involved with the early stages of endoscopic vein harvesting in UK. You need to choose your patients very carefully, otherwise you will get early failure. So the best patients are the big fat diabetic patients, because it's quite easy. And we try to use less CO2 nowadays, because you can have even systemic CO2 rise as well if the CO2 pressure is too high. So those are the things. And then the side branches, how do you clip them? Because there's a tendency to damage the vein as well. And some of the early concerns that has been raised regarding EVH was due to the injury to the veins. So I congratulate you on your excellent results otherwise. Thank you.
Thank you.
Our next speaker is Dr. Shakil Farid from UK. He will deliver speech on intraoperative graft flow measurement during CABG.
Thanks to the organizers for inviting me to give a talk in this beautiful conference. I thought my talk actually sits very well with Dr. Prashanto Chanda's talk, where he said that never accept suboptimal results. So those of you who have visited Las Vegas, if you have visited Hafiz Bhai, you would have seen this heart attack grill, where if your weight is more than 350 kilo, you eat free. You eat for free, as much as you want. I thought since it's a post-lunch, postprandial session, it will be good to put up this slide at the beginning. Anyway, back to cardiac surgery. So how are we doing with regards to mortality following CABG? The mortality is actually extremely low. If you look at the UK data, for patients who are having non-emergency surgery, the mortality is only 0.1%. 0.1%. It's unbelievable. So 100 patients you are operating who are having urgent cases, elective surgery, only one of them are dying. So it's fantastic. What about the graft patency? Although it's an old graft, it's a bit disappointing. If you look at the vein grafts, 40 to 50% of the vein grafts are not patent after 10 years, which is really bad. Okay. Sometimes I compare cardiac surgery or CABG with false economy. So if I'm a developer, you ask me to make a building for you, I will use the cheapest material, because I don't care about the long-term results. I just care about the short-term result. I hand you over the building, you're flat, you're happy. First 1 year, nothing happens. I'm happy, you're happy. And then after second, third year, disaster happens. And CABG is a bit like that, because what we are doing is we are just looking at a crude indicator. We are looking at the mortality. Mortality is 1%, patient goes home, we are very happy. After 6 months, patient comes with recurrent angina, or after 1 year, patient falls dead. And then that gives more ammunition to our fantastic cardiology colleagues who say that, look, CABG is never good. PCI is always better. You don't have to crack the chest open. How does this fail? How does the grafts fail? We know the long-term and short-term problems. On short-term, most problem is technical error. endothelial injury. If you look at the data, different papers, intraoperative technical failure happens in 5 to 20% of cases before discharge. 30% of the grafts are occluded by first year, okay? Now, why does it happen? Because of technical problems like kinking of the graft, long graft, short graft, all sorts of problems. So where are we heading? We have to improve our other outcomes, other parameters. Like if you talk about the future of cardiac surgery, on long term, we have done lots of things. We are giving the patients the good medications. We are giving antiplatelets, statins, and all kind of medications. Short term, there's still a lot of room for improvement. And that improvement will come if we use more arterial grafts. We measure the flow of graft intraoperatively. We do the secondary prophylaxis. We do procedures which has low complications. We do MICS, which has been very elegantly shown in my last presentation, in the last presentation. And then, of course, you do a lot of things to improve the venous patency. You do non-touch technique, you do EVH, you sometimes vest, which is an external stent that can be used. All these things can be done. If someone undergoes plastic surgery, they have their results immediately. So this is Donatella Versace, whose plastic surgery went really badly wrong, and there was a $1 million case. If you do a mitral repair, you have beautiful TOE images to prove that you have done a proper repair. If you do aortic surgery, there's beautiful CT scan to show that you have done aortic surgery properly. What about CABG? CABG, we don't do anything. Most of the centers in the world do not have any kind of intraoperative flow measurement for CABG. What does our guideline say? Guideline strongly recommends. It's a 2A indication, and it will be upgraded in the next one, that routine intraoperative flow measurement should be done for patients undergoing CABG. Now, let me show you an interesting study. In this study, there's a group 1. This is from Japan. In group 1, patients had less than 75% stenosis. These patients are having all sequential grafts. I know sequential graft is very popular in this part of the world, especially with arterial. Group 1 has less than 70% stenosis. Group 2 had a sequential graft. The proximal graft has 99% stenosis. Distal graft had 75% stenosis. Third group, the fantastic Y graft. I know this is one of the most popular, elegant graft in this subcontinent. So the third group had 75% stenosis in the LAD, and in the other vessel, there was 99% to 100% stenosis. You know what happened? 1.1% grafts were occluded, and these are by immediate postoperative coronary angiogram. More worryingly, 4.5% grafts had competitive flow. We know these grafts in the long run will not stay patent. You know why it happened? Because there was backflow. So if you're doing sequential, it's absolutely fine. There are lots of good surgeons here who can do very good sequential grafts. You have to know where to put that in. Now, the moment you start making an operation complicated from a simple operation, you have to have some sort of measurements for seeing how the thing is done. I mean, this is a famous paper by Moreno Gudino, which shows basically in patients with stenosis of less than 70%, no matter what kind of graft you put, the outcome is worse. Probably with IMA, the outcome is better. If it's a radial graft, almost surely the radial graft is going to block off. If it's a vein graft, probably the vein graft will stay patent for a while. So all these things are really important. Now, how can we measure the intraoperative graft flow? So there are a lot of techniques that has been used. Conventional angiography was used, but it's not feasible. If you have to take the patient to a cath lab for a coronary angiogram, it's not going to work very well. Then other things have been used, but two things only stood the test of time. One is transit time flowmetry, which I'm going to talk about, is the Medistim thing, and intraoperative fluorescence imaging, which is also used. I don't think it's used that much. Medistim is the one that is used more. When we review the studies with intraoperative fluorescence imaging, we see that 1.7% grafts underwent revision. Then when we look at the Medistim, the transit time flow measurement, more worryingly, we see that 3.2% grafts were revised. So it's a big number. If you think of it, it's a huge number of patients we're talking about. what exactly is this machine? So there is a monitor in this machine where you can see some numbers. There are two probes. One probe can be used as an epiotic ultrasound. Another probe is used to measure the flow in the graft. This is the flow, which is a probe which is used to measure the flow in the graft. And this is the one which is used for epiotic ultrasound scan. So it's very useful if you have an intramyocardial LED. You can actually put the probe on the heart and see where the vessel is. You can pinpoint the LED and you can make your cut there. We have all faced situations where we couldn't find the LED and we had to dig a big hole in the heart and later regret it. And the other part of the probe, with that, you can actually measure what kind of flow you are getting. Now, what are the things you're looking at? What do you find on the monitor? The first thing you see is the mean flow. 70 ml per minute flow is excellent. Most of the graphs won't have this flow. Then you look at the flow pattern. Flow pattern, even if you don't understand the flow pattern, you see a good flow, that's good news. Then you see the acoustic coupling indicator. This is important to understand what kind of contact you have with the vessel, because if the flow is less and your ACI is less, it means that you are not putting the probe in contact with the vein or artery, whatever you have put in. And then the most important thing, the PI, which is a pulsatility index, it's essentially the resistance. If you have a vessel which is not significantly diseased, your PA will be high. Or if you put a stitch inadvertently in the toe during doing off-pump or on-pump bypass surgery, your pulsatility index will be very high. And then you look at the diastolic filling pattern. So practically, when you do this, the most important three things you look at are the mean flow, pulsatility index, and the diastolic filling pattern. And what they have shown is with lots of cases being done, if your PI is less than 3, your diastolic filling is more than 50%, and your mean flow is more than 20 ml per minute, you are safe. Your graft is actually good. However, if your flow is less than 10 ml per minute, your PI is more than 5, it means your graft is not patent. PI between 3 to 5 is a gray zone where you actually have to think, and that's where your interpretation comes into place. Or if you have a mean flow of 10 to 20. Now, if it's a LAD, 15 ml flow is above 15 ml is probably acceptable. If it's a vein graft, it has to be at least above 20. So you can see a Lima 2 LAD anastomosis where the flow is good, the PI is low, so you don't have any worries about this graft. Then you do a Lima 2 diagonal, you see the flow is 9 ml, the PI is low. It's fine because probably the vessel is not great. You have done a good job, but this is what it is. It's not going to get any better. We also use another machine in Cambridge. We are testing this machine. It's like a spyware. It's like a camera where you do the graft, you take the clamp off, and you check the flow in the vessel. This is at very early stage of development. Problem with this is you can see the flow, but it's difficult to quantify what kind of flow you are having. So it's still in experimental stage, and hopefully we'll get some results in the near future. Now, when do you have issues with graft? You have issues with graft when you have a high PI, low diastolic filling, and low mean flow. What can be the causes? The causes can be a compromised anastomosis or an intimal flap. Sometimes what happens is if the vessel is very calcified, you can get an intimal flap. Then more worryingly, graft placed proximal to the stenosis or placed on a vein will give a wrong flow. So once one of the registrars had a 500 ml per minute of flow, he called the consultant to boost that. What a fantastic job he has done. The vessel has 500 ml of flow. All of us who do cardiac surgery, we know that you cannot have 500 ml per minute flow in a LAD. He essentially put it on a vein. That's why the flow was so high, That was identified because of this machine. So the consultant scrapped up and did the case. Competitive flow, we come across quite a lot, especially if you are doing a diagonal graft and you have a Lima 2 LAD in place. Dissection of the conduit or the artery, that can be identified very well in this. Spasm of the arteries, that is also good. So if you have a good flow initially and then something happens, you see a bad flow, you know that there is something to do with the spasm of the arteries. Kinkton twisted grafts or short grafts are very good to understand with this. And obviously, you have the graft occlusion. I'm not going to go into the details. Those who use it regularly, there is a chart which you can follow to find out exactly what's happening when your flow is low, pulsatility index is high. And there are lots of studies to show, like 3.2%, roughly 3% of the patients undergo revision surgery if you use this. And out of these 3% grafts, 92% problems can be sorted out if you redo the graft. So what you're doing is you're making sure the patient leaves theater with a patent graft, which is extremely, extremely useful. Some examples of graft issues, you see the Lima 2 LED graft was done, the PI was 12, which is sky high, flow was only 2 ml, diastolic filling was only 6%. It was redone and the flow improved. SVG to OM graft, flow was only 7 ml, PI index was very high, diastolic filling was very low, graft was actually too short. When it was lengthened, you see the flow increased and the PI improved. So this is a case, this is a classic case where it shows that how important it is to do a top end properly. It's not about just doing the bottom end properly. Then competitive flow is very important to understand. You know, if you have competitive flow, you won't get good long-term results. So a patient had competitive flow, and then what was done? There was no technical issue. The proximal vessel was snared. After proximally snaring the vessel, the flow improved, which means that technically you haven't done anything wrong. This vessel was not properly diseased. Few tips when you are doing this, you need to make sure that your map is above 65, 70, and you have to make sure that your vessel is not kinked. There's no air in the vein graft or arterial graft. And also you should ideally hold the probe very close to the anastomosis, as close as possible to the anastomosis. Classical example of use of this is this patient who, in my view, should have had a stenting, but somehow the patient underwent surgery. And can you please, I'm coming to the end. So yeah, so basically the patient ended up having surgery. 2 grafts were placed, and what happened was one graft was, so the vein graft was actually feeding the LED territory as well, and the LED flow was down. So what was done was the vein graft was actually clipped and everything was fine. So I have discussed all these things, especially if you take repair suture or you're trying to sequentialize graft, using this machine is very useful. So finally, in conclusion, we have all these tools which we need to use for giving the best results to our patients, but you need to use your clinical judgment as well. Nothing can replace your clinical judgment, and only then we'll achieve good results. Cardiologists are much closer than you think they are. You know, all they need is good medications, better stents. You know, if we are to fight with the if we are to give best results to our patients, we have to make sure that the patient leaves operating theater with a well-patent graft. Thank you.
Thank you, sir. Thank you for your enlightening speech. Do you have any questions? Ladies and gentlemen, house is open for your questions. Any question to speaker? Few questions.
Yeah.
Excellent presentation and
Thank you.
of interest. Obviously, we all would love to technology as is possible, but obviously because of the cost constraints on this
Yeah.
part. So, in your opinion, you've been using.
Yeah.
What would be the sensitivity and specificity? I understand there are a lot of papers suggesting, some are suggesting 70%, some are suggesting 80%. There's a
Yeah.
very rough data lying around. So what is your opinion?
Thank you. I think it's a very excellent question. And the answer is no one knows about this. Because if you look at the literature, the sensitivity and specificity varies between 70 to 90%. I mean, depending on which literature you look at. What I find is, normally, if you have any worry about a graft, when you use that and you look at the whole clinical picture, there is usually a problem. So say, for example, if you can't come off bypass or if you're having arrhythmia, then when you do the grafts, check the grafts, and you see problem with one graft flow, you know that there's problem with that graft. Whereas, if you have low flow in one of the grafts or borderline flow, but there's no ECG changes, there's no echo problem, patient is well, then I think you wouldn't do anything to that graft. So it's all a guess game, but clinical judgment is very important, but I think it's very useful, especially like in our center in Cambridge, 99% CABGs are done by our registrars with a consultant standing opposite to us, opposite to the registrar. So when I take my registrar through, I don't know when he has done the Lima to LAD or Rima to LAD or radial artery, how much tension he's doing when doing the purse string. And occasionally in situations where you don't want to touch the aorta and you are sequentializing the grafts, you need to understand what flow is going where. So I can give you an example where I did a graft to the diagonal, I did a graft to the LAD, and the LAD flow was very good before we took the cross clamp off. As soon as we took the cross clamp off, the LAD flow reduced after I plugged the diagonal graft. And then when I clipped the diagonal graft with a clamp, the flow again increased. So I ended up clipping the diagonal graft. There is a very good study from Japan where they have shown that patency of Lima to LAD graft is inversely proportional to the number of diagonal grafts you use. Because most of the surgeons in the world use a vein graft for a diagonal. And what it does is if the Lima to LAD is not a significant lesion, the LAD lesion is not significant, it feeds the LAD and blocks it off. So this tool is very useful. Another situation where I found it very useful is when you have an anonymous RCA and you put a Rima on the distal RCA, then the question comes whether you clip the RCA or you don't clip the RCA. Because as you understand, it's a dynamic situation. The RCA is coming between the pulmonary artery and the aorta. Now, having this is very useful in that situation. So I think it's very useful. And the final thing is, all of us, no matter how great surgeons we are, we had situations where we had to put extra repair stitch in our distal anastomosis. Now, if your flow is good, and then you put a repair stitch, your flow is down, you know that you have done something bad. So you can always revise that. So that's why I think it's very useful. Thank you.
So
Thank you.
in your center, do you perform this test in every cases?
So in Oxford, we used to do it for every case.
In your center?
Yeah, so I was in Oxford before.
Yeah.
3.5 years I used it for every case. In Cambridge, we are investigating another instrument, another tool. That's why we are not using it for all cases. But the plan is to use it for all cases. But if you look at the NICE guideline, it's recommended to be used for every single case.
Do you use ultrasonographic testing?
We use it if there is any doubt. Yes, we do epiaortic ultrasound routinely if there is any doubt. I think in USA they do it for every case.
But in our center, in early 90s, we used ultrasonography.
Yeah.
Almost in all cases, when we are just learning
Yeah.
for CABG,
You mean epiaortic ultrasound?
vascular ultrasound.
For what? On the aorta or on the LAD?
For LAD.
Why did you do LAD ultrasound?
Lima to LAD.
Okay.
CABG.
I think in fairness,
But after experience, after our good period of experience, we didn't require, and because we could understand with the pattern of the flow of the vessels, the head of the vessels, the way of anastomosis, give us clear indication that the flow is okay. At least what that aorta can give, what that blood pressure can give, it is okay. If any doubt, then we could call for the ultrasonography assessment. Is it practical to test for all the cases? We do 2 cases per day.
so I think if you have VeriQ available in your hospital, it's better to do it for every single case. That's what I would recommend. Now, cost is an issue. Believe it or not, although I work in United Kingdom, cost is a bigger issue there because we work in the National Health Service. We have to justify. But if you look at evidence, actually there is very strong evidence to use it for every single case. Now, I think you work in CMH, which is CMH, isn't it? You work in Army Hospital, right? No? Where? Huh? NICVD. Okay. So, if you have plenty of money and the patients are happy to pay for that, you should use it. If God forbid, if I need a CABG, I would ask my surgeon to use it, and I will pay extra if necessary. With the ultrasound probe, I do not think you can actually understand very well what's going on. You have to be extremely experienced to understand what's going on. Yeah.
Now these machines are coming in the market.
Yeah.
Now this 80 kilometer is coming in the market.
Sir, we are already running short of time, sir. Sorry, sir.
Absolutely.
Thank you very much, sir.
Thank you.
No
Thank
more
you very
question
much.
for this speaker. Our next speaker is Dr. Ruhul Abid, sir, from USA. He will speak on coronary artery resilience.
So I would like to begin by thanking the organizers and the chairperson, panelists, and respected audience. So my topic would be on a little different. So I think it's a more futuristic. So hopefully or our team will be able to solve the issue of PCI or surgery, which one is better and which one is not. So because we are aiming for some non-invasive technologies in future. So let's see. So let's begin with the first slide. Okay, so while the slide is being uploaded, so my topic is I would like to show how the coronary vessels can be activated or remained kind of patent during myocardial infarction or during chronic myocardial ischemia. So the main goal is to change the metabolism of the coronary vessels, coronary endothelium during ischemic myocardium, during myocardial ischemia, so that it can survive the ischemic changes. Is the slide there? Okay, so in brief, because I have some disclosures, I need to show that. So in brief, what we do different models. One is from CABG patients' atrial tissue. We harvest that. We have a transgenic animal model where you can express targeted gene in endothelium, coronary endothelium. Another, we do bone marrow, human bone marrow derived extracellular vesicles injection, so in the heart. Another is a nanoparticle, but all of these are targeted for mitochondrial reactive oxygen species regulation. So, okay. Yeah, so I'll begin my slide. So that's the title, Coronary Vascular Resilience by Metabolic Shift. And the disclosure is I have a few NIH grants, and I'm also a CSO, Chief Scientific Officer of newly founded therapeutics. Another is a consultant for ARI Science. Those are all US based, but nothing to do with this study, only the funded grants from NHLBI, which is National Institute of Health. This is Brown University, from where I am. And this is our lab. So it's called Cardiovascular and Global Health Research Lab. So I'll present the cardiovascular side research lab today. So since at the end I may not have time, so I'll begin with the people who are behind their work, because I'm kind of presenting their work. So they did the main work actually. So these are all students, residents, and some faculty, junior faculty work with me. So this is just very recent from American Heart Association annual scientific session meeting, Chicago, in last month, November. We're coming from there. So they are, so the Sharif Sabe, he's from Harvard Medical School, and Cynthia from Brown. So they have been, so Sharif actually works with me and Dr. Frank Silke, and Cynthia works with me. They are T32 fellow from NIH fellows. So they got the, for the study I'll be presenting, they received Vivian Thomas Finalist Award. Every year they select 5 people, residents, so they got that. They didn't get the award though, but they were among the 5 finalists in the USA. And there are 2 past residents. One is the closure one is Laura, the further one is Brittany. So they worked before on this project. So some of the projects I'll be showing actually part of their results. So Brittany is in now MGH doing pediatric surgery, and Laura is doing UCSF cardiology fellowship. And this is another picture. This is Dr. Hayani, who is a postdoc from, she graduated from Brazil and joined our lab. So she is presenting in American Heart Association, the work I'll be showing today. So in brief, like, as you know that the cardiovascular disease is the leading cause of death globally. But if we look at the age breakdown, so say if 0 to 29, you'll find that out of 11 million deaths is 2 million. When it goes to 30 to 69, then it becomes totally different. Out of 20 million, there are 14 million deaths from NCD or mostly cardiovascular disease. Then age 70 plus, it's like out of 25 million, 22 million are from cardiovascular disease or non-communicable disease. So what we are trying to do is, because there are several studies which showed that a significant number of people, they are not eligible for surgical procedures or any surgical interventions, and many do not receive timely intervention after MI. So 15 to 20% do not receive timely intervention, that's globally. And then only in USA, there are 200,000 deaths per year, and globally 3 million deaths because of they do not receive the timely intervention. So major research aims of our research group is non-invasive therapy, development for non-invasive therapy. So what we are doing is improvement of perfusion in ischemic myocardium, then prevention of myocardial infarction, and induction of coronary angiogenesis in post-MI or collateral development in post-MI heart. So the model we are using, as I mentioned, that's CABG, atrial tissue, then human coronary artery endothelial cells, the purified one, the transgenic animal, then mitochondria targeted nanoparticle therapy, and then extracellular vesicles from human bone marrow derived stem cells. So all the main purpose is to induce coronary angiogenesis by changing, modulating mitochondrial function, because mitochondria plays a very important role in coronary endothelium and as well as myocardium definitely. But coronary endothelium is usually very much dependent on mitochondria, not for ATP synthesis, for other purpose. Because in endothelial cells, usually ATP synthesis occurs through glycolysis, not mitochondrial oxidative phosphorylation. So we found that the take-home message from this talk is, if you reduce mitochondrial ROS, coronary vessels may survive in ischemic myocardium. So that's the take-home message from here. Anyway, so there are three models. The last two models I'll be presenting: the high-fat fed pig model and genetically modified mouse model. So this is a model for which we are showing that mitochondria on the right side is actually playing a major role, and how we modulate that by nanoparticle, by genetics, will change that. Because mitochondria, this is inside mitochondria, you can see that mitochondria generates a lot of superoxides. So MNSOD, or the nanoparticle we are using, that reduces superoxide in mitochondria. And what it does, because mitochondria plays a very important role in respiration and other purposes. So if you see at the top left side, you see that there is, if you have one glucose in glycolysis, which is coronary vessels do, they do not produce ATP by oxidative phosphorylation, they do glycolysis. So during glycolysis, one glucose molecule on the left side produces only 2 ATP. And on the right side, if you see that right bottom side, that oxidative phosphorylation, you can produce 36 ATP from one glucose molecule. So if you can make that change, conversion of ischemic myocardium during that myocardial infarction or chronic myocardial ischemia, so you can make a coronary vessels resilient, so that getting a very small amount of glucose, they can survive, because during that ischemia, there is lack of oxygen and lack of glucose both. So that's one model. Then another is we are doing extracellular vesicles from human bone marrow derived stem cells. So these vesicles actually very tiny size. It's like 100 to 200 nanometer, and they have DNA, RNA, and we inject that in pig heart and in pig heart and mouse heart. So here you can see at the bottom that there are ongoing phase 1 clinical trial for extracellular vesicles in intracoronary infusion at this point. So we don't know, have the result yet. We're waiting for that. The peak protocol we used, I showed the surgery residents. What they do is, you can see this is amyloid constrictor, and that amyloid constrictor we place on left lateral circumflex artery. I'll just briefly go through this. because you guys are familiar with this. So we place that amyloid constrictor. You can see the constrictor is placed, that metallic part, and that actually slowly constrict the vessels. It takes around 2 to 3 weeks to make it ischemic. So it's not a chronic, it's not an acute infarction, it's a chronic slow ischemia. And then we inject extracellular vesicles or that nanoparticle in that pig heart, and after 4 weeks, we measure their cardiac function and harvest the tissue to analyze. This is an acute infarction. We do it in a small animal. You see the LED ligation, and you see that after 1 week, there is a significant infarct, and then 5 weeks, it's further pronounced. So this is just showing briefly that so what we found is when we inject extracellular vesicles or nanoparticle, which targets pig heart, so they become better. So myocardial perfusion improved. But one thing is we're injecting in heart. So we wanted to do it intravenous. Intravenous didn't produce any results. Why? So that's what we are analyzing now. Intravenous injection, when you injected, you can see all went to liver. This is a fluorescence extracellular vesicle diet. All went to liver and spleen. So reticular endothelial cells are playing some role there. So now we have developed a lentiviral. So that lentivirus has a cardiac peptide specific sequence, as well as CD47, which can evade the immune response. So those double genes we placed on lentivirus, which will be mixing with that stem cells, and that will produce extracellular vesicles containing that cardiac peptide, so targeted gene delivery to heart. So that's we are doing now. It's already done as I speak. So we'll be injecting that soon through the vein and find out whether it goes to heart or not. But this is very exciting. And this is genetic model. I'll just skip quickly that we have that, as I mentioned, that you can see that the gene can be specifically expressed in myocardium, in coronary vessels, where you are seeing that lower panel, that TET-off, you can see that there is red and green making yellow color. That means they have gene expression for mitochondria specific gene in coronary vessels. Okay, so this is nanoparticle, which mimics like mitochondrial antioxidant. So this nanoparticle we plate with, this is electrospinning machine. You have a biocompatible polymer, which we connect, load this drug, mitochondrial antioxidant drug with this polymer, and that you can place on as myocardium as a patch, which will release the drug for 2 to 4 weeks at a sustained rate. You can modulate that changes by, on the right side, you can see the nanofibrous electron microscope picture. You can change the diameter and you can modulate how much they should release during 4 weeks or not. And there is another development ongoing, that's electromagnetic. So you place the patch inside the heart and you can control from outside by agitating the nanoparticle by magnet, so that you can release it when you want and you can stop it when you don't want. These are some data just showing echocardiography and the results. I'll go briefly. And this is on the right side. You can see that significant changes in capillaries in the lower. So the endothelial cells are kind of still alive, and they are proliferating. They are making new blood vessels during ischemic myocardium, in ischemic myocardium during that myocardial ischemia, because we modulated their mitochondrial oxidant level. And this is the kind of ischemic, this is a model schematic that's showing that on the left side is a normal heart, and right side, if you reduce mitochondrial arrest, you will have better angiogenesis. And this is just to remind everyone, if it's a little confusing or not, that this is mitochondria, and you see that on complex 4, on the upper right side, on complex 4, that's the only one place where we need oxygen. All the oxygen we breathe in is because of that complex 4. And that complex 4 requires oxygen. That's why we require oxygen. Otherwise, would be fine without oxygen. So these endothelial cells are actually shifting from glycolysis to oxidative phosphorylation to make more ATP with a limited supply of nutrient. Instead of 2 ATP, they are making 36. So you don't need to give them any quick reperfusion, hopefully. So we are testing that by ischemia reperfusion, acute myocardial infarction, chronic myocardial ischemia, 3 different models in pig. So hopefully next time we'll have some results from there. And this is an instrument, it's called seahorse, it can measure mitochondrial respiration. So it shows that this really increased mitochondrial respiration in coronary endothelium. So conclusion is that we have an ongoing project which has a lot of kind of significance, but it's all in the future. Nothing is done yet, really. Thank you. Thank you very much, and it's a pleasure.
Thank you, sir. Thank you very much for your very informative scientific paper, sir. Ladies and gentlemen, because of the severe time constraint, we are sorry we cannot entertain any more questions for onward speakers. Our last speaker is Dr. Sudhir Adalit. He will deliver on concomitant LA reduction with mitral valve procedure, our experience.
Good afternoon, everybody. At the outset, I would like to thank National Heart Foundation and especially Dr. Farooq for for letting me be here and presenting in front of you. I'm Dr. Sudhir Adalti. This is my first time to Bangladesh, so very nice and humble people here. But yes, the traffic is so still waiting. I work at Apollo Hospital, Ahmedabad. It is the western part of India, exactly opposite of the border you share with India. Not sure. It just when you connect HDMI. No, the HDMI is there. Oh. Yeah, chalega. It should work. This one. Oh, now where is that? There's nothing to work at all. Seated. No, no, no. I think it is working. Yeah, very good. It worked. So this is about concomitant left atrial reduction with mitral valve procedure, a single center experience. This study was conducted at my previous hospital. It was a public hospital. So these all patients were the patients on whom we were to operate mitral valve. And along with that, we had a giant LA. So giant LA is left atrium is defined by a mode measurement of more than 65 millimeters. And if it is indenting the left ventricle postero-inferiorly by more than 30 millimeters, that's how it is defined. And giant left atrium, whenever it is associated with mitral valve, we generally tend to address it. So if you see, this is the definition by M mode echo diameter more than 65 and dilated LA atrial cavity with and bends more than 30 millimeter in the long axis view. So Hewitt was the first one to describe giant LA in 1849, and 1967 first successful attempt was made to manage giant LA. However, the mortality rate was pretty high. So why do we need to manage giant left atrium? So because of the hemodynamic complications, it compresses the right heart cardiac chambers, it compresses the IVC, it compresses the left ventricle. Because of the respiratory complications, it widens the angle of the carinal angle and compresses the left bronchus. Most of them, whosoever has LA size more than 40 millimeters, tend to go into atrial fibrillation, lending to thromboembolic complications, including the atrial thrombus formation. According to some studies, the size of the left atrium is a predictor of sudden death also. So analysis of the data from Framingham study showed that an increase in left atrial chamber in the presence of AF was associated with an increased risk of stroke and sudden death. So those are the, I think, sufficient reasons that we should handle our giant LAs more cautiously. So this was the landmark paper, impact of left atrial volume reduction concomitant with AF surgery, although not with mitral valve, but with AF. So they found out that the Mays procedure concomitant with LA volume reduction surgery not only facilitated sinus rhythm recovery, but also improved the LA geometry and promoted left atrial reverse remodeling. And it helped improve both active and passive emptying of the left atrium and positively contributes to left ventricular filling. So why not? Why aren't we dealing with giant LA? So problem is bleeding, extra time taken for the surgery, and psychological block. As in valve repairs, there was a huge mental block on the part of surgeons, and once they started doing it, now I think most of the surgeons are dealing with these mitral repairs very well. Same is the case with left atrial reduction. It's a huge psychological block on the part of surgeon, fearing of the complications which haven't happened. So I think we must go ahead, take one step at a time and deal with this. So these were the various methods. Classical wall plication, this was the initial one. That's how it started, plication by Danielson. And then the Mercedes plasty of the inferior wall they did. Then triangular resection, then the plication of the superior and inferior, then the spiral resection, and then also the partial heart autotransplantation. So in our study, we modified it a bit. So I'll show you a video later on as to what we did. So this was from 2012 to 2015. We enrolled only 25 patients initially, out of which males. This is the demography. And mind it, 23 patients had permanent AF and 2 patients had persistent AF. And all of them were around NYHA 3 and 4. So this is our intraoperative statistics. CPB time wasn't too different, 74 minutes. Cross clamp time only 51 minutes. So the time taken wasn't that much long. Pre-op LA size was 94.5 plus minus 11. Post-op LA size was only 40 plus 1.35. Follow-up was around 5 years. Most of them were in NYHA class 1 and 2. Most importantly, that AF, sudden bouts of AF for which we put them on a lot of medicines, they had gone. Normal sinus rhythm was in 24 patients out of these 25 in follow-up for 5 years. And another 1 patient was in controlled AF. So these are some of the echo pictures. So these are the pictures. So actually what I do is I extend my paraseptal classical LA incision inferiorly into the inferior wall and go through the posterior wall and through the roof, thus separating the right pulmonary cuff from the left pulmonary cuff. So basically divide the heart into 2. This is what when we put sutures. So if this runs, yeah. So I divide the left atrial appendage exactly, first excise it and suture the rest of the left atrium back together. So the left atrial appendage is taken care of first. So here you have to be careful about the circumflex, 5 millimeters away from the circumflex. So this is the incision which I have extended and divided the right and left pulmonary cuffs separately. And now I am assessing the posterior wall and the superior and inferior wall as to how much I have to excise, how much room is there. Remember, there shouldn't be too much tension when you are suturing them back together. And when you extend the paraseptal incision inferiorly, there is coronary sinus just nearby. So you have to be careful about that also. So here I'm excising the same posterior wall, assessing as to how much I can take it out. So this is the So we suture it back in double layer. Initially I used to suture in double layer. Now I'm good enough. So we do it in single layer. You can see. So this was the results, and it was published in Innovations in 2018. So conclusion was the concurrent left atrial reduction with mitral valve procedure is a feasible and effective technique for event-free survival of the patients having giant LA with mitral disease. So you can see the same data has gone into this paper. Thank you.
Thank you, sir. Thank you very much, sir, for your very enlightening speech. Ladies and gentlemen, because of our very severe constraint, we are already running behind half an hour time for the next session. We could not entertain any questions. Thank you very much, sir. The prize and cash will be delivered outside. Thank you very much. We are very sorry and very grateful to our next session speakers and respected audience for this delay and tolerating us, holding your emotions. Thank you very much, sir.